In that case, we'll get on to our first speakers, which are Alison Bennett and Catherine Patrick, who are CNSs for lung cancer at Barnsley. I'm going to talk to you about the Barnsley lung pathway.
So I'm Alison, I'm the lung cancer nurse specialist at Barnsley District General Hospital. I've been in post for 19 years and seen a lot of changes. But just at this moment in time, there are a lot more changes coming on board. So I'm just wanting to talk to you about the new Barnsley, it's rapid diagnosis pathway. And this was developed for many reasons, really. The main ones being the publication of the National Optimal Lung Cancer Pathway, which has to be embedded in practice for all hospitals by 2020. We have to have plans in place by March 2019 to show them how we're going to deliver this pathway. Also, Barnsley, we were not meeting the 62-day GP referral to treatment target, and we needed to streamline the patient pathway and improve the patient experience. I do apologise for the busyness of this slide, but this is the pathway that we've had to work towards. It has been, directed from us nationally. So we've developed the Barnsley pathway according to this and according to what resources we've got and what our current services are. So in brief, the pathway, you will request a chest x-ray when you've seen a patient you think they've got, they might have lung cancer, and previously you've done it and referred to a 2-week wait clinic. We are no longer calling it a 2-week wait referral. We're calling it the rapid diagnosis pathway. And we, the request is via the eye system when lung cancer is suspected. Abnormal chest x-ray results are then flagged up to myself and my colleague, Catherine. We contact the patient to discuss the x-ray and also what will be happening next. And we will also contact yourselves. It's usually by the receptionist who puts a note on the patient's notes to let you know that we've actually picked up this abnormality and we will be acting on it. Once we have the abnormal chest x-ray result and contact the patient and yourselves, we then request a CT scan. If the CT scan is abnormal, then we will refer to the Rapid Access Lung Clinic and we will also write to yourselves. We check the reports. If it's normal, we will send a letter to you just to say that there is no evidence of lung cancer for this patient, and we let the patient know. If it is abnormal, then we arrange the next appropriate investigation, and we've developed a test bundle based on national guidelines. So we're now able, Catherine and myself, to pencil in the next available investigation. As I've said, yourselves and the patient are informed. Our aim is eventually, when this is fully established, is when a chest x-ray has been reported as abnormal, we will be contacted by the radiotherapy department, the x-ray department, and we will go downstairs to the x-ray and counsel the patients on the same day, and then they will have a CT scan immediately so that we can cut down the pathway even further. So this is the new screen that you probably see when you go into ICE now. And we've removed the 2-week wait request. So now it's x-ray suspicion of lung cancer. This is because attached to that now we have an automatic drop down where user needs have to be requested. It's important that these are requested at the same time as the chest x-ray because we need the results to enable us to request the CT scan. And if we don't have the results, then it adds a delay because we're having to request the user needs, get the patient to come for those, wait for the results, and then we can request CT scan. Also connected to this, the little arrow and the paper there is a patient information sheet. So if you click on that box there, it automatically opens up a patient information sheet, which you just need to print off and hand to the patient before they leave the consultation with you. We tried to make it as simple as possible and with as little for you to do as possible so that you've got time to concentrate on other things in the busy surgeries, because we know how workload just increases for everybody. But this is just a case study from last year, well, the year before when we were doing it. And that shows how quickly we can get patients through the pathway if we have everything in place. So the chest x-ray, the reports done quickly, we can get them the appointment, investigations, and they can be starting on treatment within 26 days of having an abnormal chest x-ray. The benefit also for people who actually don't have lung cancer. This was a young lady, she was only in her early 40s. The x-ray had been reported as abnormal. She needed a CT scan. She was going on holiday a couple of days later, 2 weeks family holiday. She's got 2 young children. So we managed to get the CT scan and reported and then notify her that actually everything was all right and it wasn't a suspicion of lung cancer. So it works not only for those with the disease, but also to reassure patients who don't have lung cancer. When we looked at the information, once we'd got the pathway in place, some of the things that came up that caused a slight delay in the pathway was the fact that user needs weren't requested at the time of the chest x-ray. We don't need 2-week wait referrals now sending in, because I think previously you were doing your chest x-ray and then having to do the 2-week wait referral and completing the forms. You don't have to do that anymore. What we do need is for you to discuss with the patient that there is a possibility they may have cancer. There's also a possibility that it could be something completely different, but that they will be having further investigations to show us one way or another what this could be. And then print off the information sheet for the patients to take home so that they can have a look at it once they get home and share it with the families. So the main changes that we have done over the last 12 months are the redevelopment of the ICE requesting protocol so that you request it, as I say, on a suspicion of lung cancer. The system doesn't allow chest x-rays to be requested unless the user needs are requested at the same time. And there's also the patient information leaflet linked to that. This will also flag up to the x-ray department so that they know that that is an x-ray to be hot reported. And it's not going to be 7-day reporting, as is the standard for just a routine chest x-ray. And obviously we've done further communication and education both with primary and secondary care. So basically, to enable the pathway to run smoothly, to get earlier diagnosis, to meet the targets, because the main target is diagnosis within 28 days and treatment, well, to see the treating consultant within 3 days of that. So we are working on a very, very tight time scale. Any questions? One thing I didn't mention is if you have a patient and you request the x-ray and it comes back CT is normal, but you still have concerns that there is something wrong with that patient, there is still the opportunity for you to refer in with a clinical suspicion. So you can refer into, on the chosen book, to an urgent clinic if you are still concerned. So we're not saying, you know, if the CT is normal, don't refer in. If you still have concerns, please do refer in. Yes. Yes, that's right. That's, yes. Suspicion of lung cancer. Yes, yeah. Yes. That, we actually have to request it at that time. We're hoping to reduce the number of patients coming via that route. We will be doing further work as well in A&E, so that when patients come in as an emergency presentation, we're going to develop the pathway to include those patients as well. But for now, we're just concentrating on this. That varies. When we first started the pathway, we were getting quite a few, 5 or 6 through. But then recently it seems to have tailed off, and there are a lot more just coming through the chosen book. So now we're hoping that you don't really go through chosen book at all. You just request the chest x-ray via this system, and we'll do the rest. We are still getting about 200 new diagnoses a year of lung cancer, so it's quite a high number. Actually, I don't know how, because we have to have an x-ray within 3 days of you requested it. So, Liz, do you know?
I didn't hear the question.
Sorry. If a patient, once a patient's had a chest x-ray requested, do they go straight up to the hospital to have it done, or do they still have to wait for an appointment to be sent out?
If you consider that it's urgent, you can send patients straight through the chest x-ray.
Right, yeah.
We'll do it on the day when the attendant can ring. You can ring, yeah.
Do we have to?
You don't have to.
Emergency have to ring. If we put it in suspicious for cancer, they can just go.
They can just
Just-
go.
yeah.
We do tend to treat chest differently.
Won't get knocked back.
No.
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 The idea that you're going to be working in conjunction with radiology and counselling patients
Yes.
is great, but up until that point, the risk is that there's a patient you can't get in contact with.
Yes,
The report
yes.
comes into our box.
Yes.
Are we to assume that you're, how are you managing that? Will you just keep going until you contact them?
That's what we try to do. Very occasionally, we have to request a CT scan without contacting the patient, simply because we've tried on numerous occasions and there's just no. Often we do contact the GP surgery to say, we have been trying to contact your patient and we just can't get through, and come to an arrangement with yourselves as, on an individual basis, as to the best way to manage it. But normally we do just keep trying until we get hold of the patient, yeah.
And also, if we've got concerns about the age of the patient, or we will contact
Yes.
the GP for advice. And
That's right. So,
because obviously we're 80, 90
yeah. So if we're concerned about anything like that, then we will just ring for a bit of guidance, because we don't want to be ringing somebody who's 92, who, you know, maybe not, lives alone, has dementia or whatever, and is not able to fully understand what's going on.
So how much of a suspicion do you have to have? Because if you're often 3 weeks
Conf- whatever suspicion, because any suspicion, no, because we're on X-ray is going to be, we're not, because we only get the abnormal ones. Yes. Any suspicion, any of the red flags, the hemoptysis, cough for 3 weeks, chest pain, shoulder pain, weight loss, any of, that you're worried about. Yeah. Okay. No. All right. Yes. Oh, what safety net is there if a patient, if for the initial X-ray request, No, but
So if the request's gone in and the patient doesn't contact us for their appointment, then we will refer it back to the GP surgery after we've tried to contact the patient. So we don't just cancel it, disregard it, we do try to contact the surgery.
one more? No, that doesn't. No, no. You have to request it. Yes, it's still the uni has to be within about 3 weeks. And if they're diabetic, it has to be So just yes, yeah. If they are, then the CT department, once the CT is requested and we've put down the values of the U's and E's, then they do anything that's necessary to, if we've requested it with contrast and the U's and E's aren't good enough to have contrast, then they will do it without. I think I have to stop now, do I? If you've got...
Still put through this pathway, if they find it abnormal, the next one still goes straight down.
But I don't know. Right. Yep. That's fine. Yep. That's fine. If it's on the letter and you print the request off, I don't know. That's what. Yes. There is. Yes. There's an information letter which tells them about. No, because we presumed that you would have done them at this time when you requested the chest X-ray. That's fine. That's fine. That's fine. As long as we're aware of that, then obviously that's what we're here for, so we can, that we can work with you to make it easier for you. Yes. Well, yes, for the patient, of course. They're the centre of everything, aren't they? Oh, sorry.
Thank you. What I would say for that with the uni is, what I tend to do is print it off and give it to the patient at the time you're telling them to go for an X-ray, and say to them, right, go for a uni before you go around for your X-ray. So there's no extra demand on yourselves as GPs, and they're getting it done. It'll be ready by the time they've had it. The other thing just to mention, with chest X-rays, up to 30% are negative, even in early lung cancer. So these are the patients you need to review, even if they're a negative chest X-ray, and refer on a 2-week wait. Okay.